The opinion being held by some speech pathologists and psychotherapists is that the cause of stuttering is due to a bad parent-child relationship and that the parents are to blame for the child's stutter. Those parents might aggravate the child's stuttering. According to the demand capacity model, it is thought that parents unwittingly set unrealistic goals for their child by their own rapid rate of speech or by using too much words that is over the child's head. With the approach that has been in common use for many years, parents are persuaded to refrain from criticizing, correcting, or helping the child, or from reacting negatively to the speech difficulties in any way, and are advised to see that the speech interruptions are not brought to the child's attention by others. Results are sparse, and the studies being done includes only few children. Some of these studies of parental counseling shows improvement of the children's fluency, but the mechanisms beyond this improvement is not fully understood. These as studies concerning parents who are slowing down their speech doesn't show improvement of the child's fluency and speech rate. Indirect approaches are parent counseling and not direct therapy of the child. The aim for indirect approaches is to strengthen the child's anticipation of normal speech and self-assurance as a speaker. Most behavior modification approaches for preschool children that stutters teach a slow, smooth, relaxed pattern of speech by modeling. Usually it is made through systematic progress from one or two word utterances to longer and more complex sentences. This type of approach is generally combined with parent counseling, where the parent's role is to assist with problem-solving the child's fluency pattern. Therapy is done with a mix of indirect advisement as appropriate to the child and family dynamics, together with some direct fluency training. Starkweather report 2 studies where they made a combination of indirect therapy counseling techniques with direct treatment. Fluency improved from roughly 9% stuttered syllables pre-treatment to an average of 1.5% stuttered syllables post-intervention. Concher et al. In 1999 reported indirect advisement together with direct treatment provided to 200 families. 70% achieved 3% or less stuttered syllables within 12 to 36 weeks. Jarrers et al. In 2006 reported a clinical trial with 70 children at age 31 to 62 months. Treatment comprising clinician-assisted problem-solving of the child's fluency stressors, monitoring of speech. Emphasis was placed on modeling slow, easy speech, reducing communicative stressors, and rephrasing and recasting the child's speech to support language development. Jarrers et al. Report following results from pre-treatment mean of 15% stuttered syllables to 3% post-treatment. 11 children achieved normal fluency after receiving only the parent counseling component. They were judged as normally fluent from 1 to 2.5 years post-treatment. The other children required direct therapy and was reported much improved fluency during the same follow-up period. Franken et al. In 2005 randomized 12 and 11 children at the age of 4 years, respectively, to a program consisting of parental indirect environmental modification based on the demands and capacities model of stuttering and the LEADCOM program. Results: the children in demand capacity model group had reduced stuttering rate from 8% to 3%. The same results were reported from the LEADCOM group of children. The treatment is administered by the parents, where children's fluent and stutters utterances are commented on general schedule of correction of each stuttered utterance in combination with 5 positive phrases for fluent speech. Parents have to learn how to document the child's level of fluency. What results are reported? Many studies are reported from this research group. Treatment effect seems to be long-lasting from 2 to 7 years post-treatment, a long-term follow-up study of 43 treated children. And it's a reference to Lincoln and Onslow. And we have different here. The delayed auditory feedback, the DAF, used to introduce prolonged speech targets. The frequency altered feedback, the FUF, creates feedback that emulates choral speech to ease the person's own speech production. However, it's still controversial. Masking noise, portable masking device to be used in stuttering therapy. For instance, the Edinburgh Masker. Portable feedback devices speak easy, both DAF and FUF. Through the developers stress that devices are best used as adjuncts to therapy, not as alternatives. The limitations here is that not all speakers, people who stutters, benefits from these devices. It seems as they are beneficial for some in combination with speech training. In recent overviews of pharmacological treatment, McGuire et al. In 2004, all emphasize that no medication has yet been shown to effectively improve fluency, and all express some concerns over risks of pharmacological treatment that may greatly exceed fluency benefit. All suggest that any pharmacological agent likely to be shown to improve fluency to some degree would have to be coupled with a behavior treatment regimen in order to achieve meaningful increase in natural and fluent speech. Another dilemma mentioned is that scientific papers concerning pharmaceutical treatment of stuttering are written in medicine, where the research design, including fluency measurements, are not appropriately done to meet the criterions for random controlled experimental design, with blinded judges evaluating the speech samples. The common factors are those factors that go beyond the specific therapeutic approach, for instance fluency shaping or via stuttering modification approach, to more global issues that might predict better therapy outcomes. Common factors include, for instance, whether therapies working with response contingencies have good outcome data, or if a therapy provided more intensively 3 weeks instead of 1 appointment time a week is more efficient, whether group therapy is more efficient than individual therapy. The most important common factors for change are the role of the clinician, the expertise, the knowledge of multiple therapy approaches, the ability to problem solve, the ability to engage the client and establish therapeutic alliance, and the client motivation, engagement, mindset in approaching therapy, readiness for change. In some studies in clinical psychology and psychiatry, the amount of variance accounted for by the therapy is much less than the amount accounted for by the clinician. Bloodstein and Bernstein-Ratner refers to a study by Wampord and Brown from 2005, where clinicians who were historically most successful in alleviating patients' symptoms actually obtained better results using a placebo medication than did poorer clinicians who administered an active pharmaceutical agent. Different parameters predicting relapse have been suggested, such as pre-treatment severity of stuttering. For instance, Craig, Jung et al. Investigations of prognosis in stuttering therapy have mostly been concerned with personality factors. Locus of control of behavior, the extent to which individuals perceive what happens to them to be a consequence of their own behavior, has been discussed as a probable instrument for prediction of relapse of therapy. However, the scientific results of the efficacy of locus of control of behavior are shown to be contradictory, poor outcome. For the time being, the answer to this question is no, not yet. There are not yet any predictors for relapse. Bloodstein and Bernstein-Ratner refers to studies concerning relapse of treatments from treatments that teaches the use of artificial speech patterns, monitoring speech techniques such as fluency shaping, or other treatments such as prolonged speech. What these treatments have in common as a goal is reduced disfluency and stuttering. To deal with the risk of relapse, an increasing number of behavior therapy programs in recent years incorporated maintenance procedures. Many clinicians have come to believe that therapeutic gains are not likely maintained without changes in some of the feelings and attitudes of the person who stutters. Retrospective analysis of the recovery of 7 adults suggested that self-acceptance and fear reduction were among the consistent themes they identified. And here's a reference to Plexico et al. Of 2005. And however, there is no information on how stuttering modification therapies or avoidance reduction therapies define and react to relapse of treatment. And that was a very long, many questions, and I think I hope I have answered them properly. And thanks for your patience.